in this slide. So we were looking at the histology of the salivary glands tissue, the major salivary glands, and then we saw that these glands secrete saliva, and we have like a production more or less of 1 liter of saliva per day. And the saliva has majorly water in its contents, but it can have electrolytes that we have in the bloodstream, like sodium, chloride, potassium, calcium. It may have sometimes even waste products like urea. And it can have enzymes, or it has enzymes like salivary amylase. Salivary amylase helps to start breaking down starch-rich foods like potatoes, corn, etc. So it begins the digestion of carbohydrates. Starch is a carbohydrate. It's made out of polymers of glucose. And then we have another enzyme, which is lysozyme. Lysozyme itself, it's a good enzyme because it breaks down the bonds of a structure in the bacterial cell walls that we call peptidoglycan. So with this, we can then make a gap in the cell wall of this bacteria, and then you have an antibacterial property then with the saliva. As well, we have another part that help us to protect against infections, like secretory IgA, which is an antibody. And this one, it is not only found in the saliva, but also is found in tears, it is secreted also in breast milk and in semen in males. And then we have bicarbonate ions, which helps for neutralizing acidity for certain foods when we ingest acids. And then those are the major components. Now, the process of salivation is something that can start by an stimulus, like smelling food, tasting food, or even imagining food. If I was about to start describing you your favorite food and you haven't eaten in a while, you will be starting salivating. And that's in anticipation that hopefully you will be eating soon. So even digestion can be basically going ahead of us before we actually ingest the food. And then we have within the brainstem a nucleus that is called salivatory. So this nucleus receives a signal, and then we will have some nerves that are coming from the facial nerve, which are motor fibers. And this facial nerve, with these motor fibers, is going to provide innervation to the submandibular and the sublingual gland so that we can have production of saliva, and also that we can have the contraction of these glands so that we can release the saliva. So cranial nerve number 7, or facial, innervates submandibular and sublingual glands, the ones that we have in this area. While the one that we have here, which are the parotids, we have it innervated by glossopharyngeal nerve, or cranial nerve number 9. And we have the release of acetylcholine onto these cells in the acini, which is like the little ending of the glands, that these ones helps for trigger the release of the saliva when they bind acetylcholine. And when someone has a medication that inhibits the release of acetylcholine, then the person will have dry mouth. That's the consequence. Now, we also have some diseases in which you have antibodies that binds to these receptors for acetylcholine in the salivary glands and also in the eyes, like Sjogren's disease. And the person will have dry eyes and dry mouth because it won't have the stimulus to receive ACH, and then it will have dry mouth and dry eyes. Now, for the sympathetic system, the control is similar. So we were talking about, when I was talking about this and the nerves is part of the parasympathetic system. But the sympathetic system also plays a role in salivation, not only the parasympathetic system. In the case of the parasympathetic system, it stimulates more serous glands or serous cells to stimulate the production of saliva that is serous, that is more watery. But in the case of the parasympathetic system, it stimulates more mucous cells so that the saliva is a little bit thicker. Okay, so those were the details about the salivary glands and salivation. Now for the pharynx. So for the pharynx, we have three regions that we already know from the respiratory system. The upper region, which is the nasopharynx, that is just directly posterior to the opening of the nose, which is the choanus. And then we have the oropharynx, that is directly posterior to the opening of the oral cavity. And then below, just posterior to the larynx, we have the laryngopharynx. So the pharynx is three muscles. We have the constrictor muscles, and these are skeletal muscles. So we have superior constrictor, middle, and inferior constrictor. And these are innervated by vagus nerve and glossopharyngeal nerves. And the oropharynx itself, it has on the sides, just posterior to the oral cavity, it has the palatine tonsils. And then just anterior, in between the palatine tonsil, but in the base of the tongue, we have the lingual tonsil. So these tonsils help to protect the oral cavity, or well, the entrance to the digestive system, the tract, by having lymphocytes that if just in case that you ingest something that it has bacteria, well, you start having the formation of clones of lymphocytes to fight these bacterial infections. Or not only bacteria, but any pathogen in general. And these are then the names of these constrictors: upper, middle, and lower. Anytime that you hear constrictor, you have to think about closing. Okay? So vasoconstriction or bronchoconstriction. So these constrictors close, but they have to open in order to receive food to pass it. And again, as I told you the other day, when we are swallowing, the upper constrictor, it dilates and goes up and receives like a funnel the food, and then once it receives the food, the stretch receptors makes it to get stimulated, and then you constrict it. And then the middle one has to dilate or relax. And then it constricts, and then this other one, the lower one, dilates and then constricts, and then the food goes down into the esophagus. So it's a sequential process then, the passing of the food from superior to inferior constrictors. And then for the esophagus, it's just as the pharynx, it's a muscular organ. And in the esophagus, remember, we have stratified squamous epithelium without clarity. And this epithelium, it's important to have it because most of the foods that we ingest are not plainly liquid. They are semi-solid or solid, and then the passage of the food itself will be so abrasive for the esophagus if we didn't have that type of epithelium. It doesn't store food, it's just passing it into the stomach, and then we need to have that protective epithelium. In length, measures almost 10 inches or 25 centimeters, and it's directly found posterior to the trachea. Remember, the anterior wall of the esophagus is the posterior wall of the trachea, and when we swallow a big gulp of water or food, that esophagus expands over the trachea, and we feel pain in the trachea. Why? Because we stimulate the nerves that are located in between. Now, the walls are made by a mucosa and a submucosa. And the mucosa, again, we have that epithelium, stratified squamous with keratin. And then in the submucosa, we have the mucosal glands that release some mucus so that the passage of food won't be entirely dry. So it will be lubricating these mucus, the wall of the esophagus internally. And then underneath the submucosa, we have the muscularis externa with the two layers of muscle, smooth muscle cells, which will be the circular layer internally and then the longitudinal layer externally. And then remember, superior third is made by skeletal muscle, which will be the inferior constrictor, and then the rest is going to be smooth muscle. So after here, the swallowing of food is voluntary. After the middle third, the food goes directly into the stomach by peristalsis. So the esophagus, it is closed upper and lower by two sphincters. So in the upper opening, you have the upper esophageal sphincter, which is located in between the pharynx and the esophagus and controls the passage of food from the pharynx into the esophagus. And the lower esophageal sphincter, or gastroesophageal, which is also known as cardiac sphincter, this one is located between the esophagus and the stomach. And this one sometimes gets irritated with spicy foods. It remains open. So when the sphincter is closed, it doesn't allow the passage of food or items, right? But when it's open, it allows it. So then sometimes with spicy foods, this remains a little bit open, and then you can have reflux of acid from the stomach into the esophagus, into what we call gastroesophageal reflux disease. And if this is chronic, the lower part of the esophagus can change its epithelium. Instead of being a stratified squamous epithelium, it will transform into the stomach epithelium, which is it is simple columnar with goblet cells. And that change is called metaplasia, and that is a precursor of cancer. Actually, when someone has chronic gastroesophageal reflux disease, the person more likely is going to have cancer, and that change before cancer is called Barrett's esophagus. Okay. So then the opening and closing of this cardiac sphincter allows the passage of food from the esophagus into the stomach. So here is the esophagus and its wall and its epithelium with a closer view. So here we have, before I talk about the esophagus, so here we have the pharynx. This is like around here will be nasopharynx, this will be oropharynx, and this will be the laryngopharynx. And then we have the esophagus here. So more or less here we will have the upper esophageal sphincter, and here the lower, which is also known as cardiac. And then if you magnify a piece of the wall, you can see here this epithelium, which is a stratified squamous epithelium without keratin, several layers of flat cells. And then this will be the submucosa with these glands that secretes mucus so that you can have lubrication of this epithelium. And then here we have the muscularis with the circular layer of cells, and then the longitudinal layer of cells. And then more externally, which is not shown in here, we will have the adventitia, which if this organ was located in the abdominal cavity, you will call it serosa. It is connective tissue that anchors the esophagus to the surrounding organs. And now here at this junction between the esophagus and the stomach, you have a change of epithelium. So see here how we have stratified squamous epithelium is this one. But here we have simple columnar epithelium with glands. So this is part of the stomach, this is part of the esophagus. And again, if someone has chronic gastroesophageal or GERD, just to not say the entire name, but constant reflux of acid from here to here, this epithelium will become this. And then it becomes cancer. Now for swallowing or deglutition. So it has the voluntary phase that happens between the oral cavity and the upper third of the esophagus. So in this case, the tongue pushes the bolus towards the oropharynx. And then from there, the food will be entering into the pharynx. And when the food enters into the pharynx, the soft palate and the epiglottis elevates, closing the nasopharynx so that the food won't go into the nasopharynx and it won't return into the oropharynx. And the epiglottis, as it's going up, also closes the larynx so that the food won't go into the wrong tube. So it will go only into the esophagus, but not into the airways. In this phase, it is controlled by the swallowing reflex. So we have in the medulla oblongata a center that help us to receive signals from the oropharynx so that we will have this movement of the pharynx up, receiving the food, and then starting the contraction of these muscles of the pharynx, the constrictors, by the glossopharyngeal nerve and the vagus nerve. So in that case, then you have the swallowing reflex, and then you move the food into the esophagus at the esophageal phase. So then your esophagus, again, will receive the food, and up to the upper third, that's where you can control the swallowing or not. But once it reaches the middle third, then you will have a series of reflex that you will have the ENS stimulating these reflexes, the enteric nervous system, so that you can have contraction, relaxation, contraction of the proximal part, relaxation of the distal, and then expansion of the distal, receiving the food, then contraction, and then relaxation. So that's called peristaltic movements. In peristalsis, basically you have contraction, relaxation of the circular layer of muscles. And then after this, you will have the passage of food into the stomach. And now the parasympathetic system in general, no matter if it's in the esophagus or anywhere else, increases the motility of the gastrointestinal tract, while the sympathetic system will be the opposite. So here are the phases for swallowing or deglutition. So in the voluntary phase, your tongue contracts, compresses the bolus of food, which is this, against the soft and the uvula, soft palate and the uvula. And then you will have this food passing from the from the oral cavity into the oropharynx. And then in the next phase, the soft palate and the uvula goes up, preventing the food coming into the nasopharynx. So it seals off the nasopharynx, and then the epiglottis It's going to go up and then it's going to close over the larynx so that the food in the pharyngeal phase passes here into the esophagus and it won't go back into the oral cavity. And then for the next phase, the esophageal phase, the food will pass from the oropharynx into the upper third of this esophagus by relaxation of this upper third of the esophagus first, and then contraction, and then after the upper third, then the circular layer of muscles in the esophageal wall are going to contract and relax, allowing the passage of food from the esophagus into the stomach. Any questions?
So peristalsis pretty much happens all the way.
Yes. Now for the stomach has a J shape, inverted, well no, actually it's not inverted. It has a J shape that is located in the upper left quadrant of the abdominal cavity. And the stomach is subdivided into major regions. The region close to the esophagus is called cardiac region. The dome-shaped region here on the left side of the cardiac region is going to call the fundus. And then from the fundus up to this last part, which is called the pyloric region or pyloric canal, we have the body. So the largest region of the stomach is the body. And then the stomach has two curvatures. One that is located superiorly, which is the lesser curvature, and one that is located inferiorly, which is the greater curvature. If you remember, we saw membranes yesterday, so the tissue that holds this adipose tissue that connects the lesser curvature to the liver, it is called the lesser omentum. And then hanging from the greater curvature, you have the greater omentum, which you can see it here. And this one is the one that helps to protect the intestines from erosion as they are moving inside the abdominal cavity, and also keeps them warm. Now, the stomach has a mucosa layer that is called rugae, in which you have simple columnar epithelium with goblet cells, and this rugae is foldings of this epithelium, and it basically increases the surface area for secretion and for mixing and also for expanding, so that this organ, when it's full, it has a reservoir of food. Now, the next layer will be the muscularis layer, in which you have an oblique layer of muscles, a circular layer of muscles, and a longitudinal layer of muscles. So the stomach, it will be the exception for having two layers of muscles along the alimentary canal. This one has three. And I told you the reason why. Because since by gravity food tends to go into this region, so then in order to bring the food from this distal region into this proximal region to mix it, because this will be kind of a mixer, then you have to have this circular layer so that you can perform this motion. So squeezing the food from here, bringing it up to here. And after the food that we have ingested, it is combined with all the secretions, which is going to be acids, some enzymes, mucus. Then that food will be made like into a paste that we call chyme. And then here we have the pyloric canal, and here is the pyloric antrum, and we have an sphincter here at the end, in this part, that is called the pyloric sphincter. This pyloric sphincter will open, and it will allow the passage of chyme little by little into the duodenum, which is the first part of the small intestine, so that you can start digesting foods in the duodenum. Okay? And now, the last layer of the stomach will be the serosa. So here is a magnification of the wall of the stomach and the epithelium. So this is the mucosa. So that's where we have the rugae. And we have this simple columnar epithelium located in these gastric glands, and these gastric glands open to this gastric pit. And within the gastric glands, we have different cells, and also within the gastric pits. In the gastric pits, mostly we have mucus cells that secrete mucus into the epithelium of the stomach to protect it from its own acids, so that you don't have auto-digestion of the stomach. So we will see later on what are these specific cells and what do they do. Now, in the next layer, the submucosa, we have a lot of blood vessels that provides blood supply to all of these tissue underneath the epithelium. And then we have the muscularis externa with the oblique, circular, and longitudinal layers, and then we have the serosa. If you magnify one of these glands, and you see them, you will see the different cells. So we have parietal cells, we have chief cells, and then we have DNES cells. So if you magnify these gastric glands, you will see, for instance, that here these DNES cells, or also known as G cells, these cells secrete a hormone that is called gastrin. This gastrin, it helps to stimulate the parietal cells, which are these, to form hydrochloric acid, or HCl. So gastrin, which is produced by these G cells, it helps for the parietal cells to produce hydrochloric acid. Now, hydrochloric acid, it is a combination of hydrogen ions with chloride. And this hydrochloric acid is made in the lumen of the stomach. It's not made inside these cells. The reason for this is because if you make this acid inside these cells, the cells will get destroyed. So the way that it happens is that you will have bicarbonate entering into these cells, and this bicarbonate is going to be broken down into hydrogen ions and CO2. CO2 is going to be diffusing out, and then chloride and then hydrogen is going to exit into the lumen of the cell and into the lumen of these gastric glands, which is here. And then chloride is going to diffuse from the basal region of the cells, which is this is the apical region. Passively, it's going to diffuse from basal to apical, and then once it's found in the lumen, these two will form hydrochloric acid. So then we also have not only these parietal cells and these G cells, but we also have these chief cells that secretes pepsinogen. Pepsinogen is a proenzyme. It is not a complete active enzyme until it combines with hydrochloric acid. So pepsin, it is made by pepsinogen when it combines with hydrochloric acid. Now, pepsin is going to break down proteins into polypeptides. And then these polypeptides will enter into the duodenum so that they can be broken down into individual amino acids. so that you can absorb them. And now, the parietal cells also produces the intrinsic factor. The intrinsic factor, it is a molecule that protects vitamin B12. And this vitamin B12 is necessary for the formation of healthy red blood cells. Without this vitamin B12, you would have something that's called megaloblastic anemia or pernicious anemia. So the red blood cells, they don't mature without vitamin B12. And vitamin B12 is actually absorbed in the ileum, in the last region of our intestines. But vitamin B12 is susceptible to the action of acids, hydrochloric acid. And with this intrinsic factor, you coat it, and then it travels into the ileum, and that's where it's going to be absorbed. Persons who have gastritis due to alcohol or other reasons, maybe they take a lot of non-steroidal anti-inflammatory drugs, they can erode these parietal cells and they don't produce this intrinsic factor. And there can be some antibodies as well that can attack these parietal cells and you don't have the intrinsic factor. In this case, you will have pernicious anemia. And what is the remedy? Giving shots of vitamin B12. Now, naturally, we keep let's say that your diet is healthy, includes vitamin B12. We keep a storage of vitamin B12 in our stomach, in our liver for around 3 months or so. But after that, if you don't ingest it, then you will start having megaloblastic anemia. So then those are the details of those cells in the gland. Now, here in the gastric pit, we have mostly these mucous cells at the neck. So these are called mucous neck cells. So this mucus then, it goes and coats the epithelium, and we have also goblet cells that produces mucus, but not as much of these as these mucus cells. So here we have the 3 phases of acid secretion from the stomach. So the cephalic phase. So when you start thinking about, I'm hungry, I want to go home, I haven't eaten. So then that stimulus of food stimulates your vagus nerve, and then that stimulates the G cells, so that the G cells secrete gastrin, histamine, and somatotropin. And that helps us to form hydrochloric acid by having a huge release of acid. Now, we have as well the gastric phase, in which you were lucky enough, you had food in your stomach, and then the vagus nerve is going to stimulate the G cells, and these G cells are going to start secreting gastrin and histamine, and gastrin is going to feed back again into the G cells, so it's an auto-feedback mechanism, and you start secreting more gastrin and histamine, and then you reduce the production of somatostatin. So you increase more production of hydrochloric acid. And then once the food passes from the stomach into the duodenum, in the intestinal phase, you will have the partially digested proteins from the pepsin that you use here to break down these proteins into polypeptides. So then once you have these partially digested proteins into the duodenum, you will have a stimulus into your vagus nerve, so that the vagus nerve stimulates your G cells to increase more the production of gastrin, so that you can release hydrochloric acid. And then, depending on the pH here in the duodenum, you can have acidic pH or a basic pH. But when you have a reduced pH, you will have something that's called enterogastric reflex. That enterogastric reflex is going to inhibit the vagus nerve and more secretion of acids because you already have emptied almost all the contents of the stomach, so there is no purpose for having more hydrochloric acid because you already have done it in this phase. And then we have as well the secretion of GIP, which stands for gastric inhibitory peptide, that inhibits the secretion of gastrin. And with this gastrin, you not only stimulate the secretion of hydrochloric acid, but gastrin also increases the motility of the stomach. Sometimes you might have heard some noise coming from the stomach. This is called borborygmus. And this happens because you have excess of gastrin, and the liquids that you have in the stomach, as they're rumbling, it creates this noise. So the stomach will have this smooth muscle cell wall that contracts and propels, like, let's say every time like 150 milliliters of chyme into the duodenum. So you push that chyme against the pyloric sphincter, that pressure opens it up, and then you release part of the chyme, and then you close it, and then your stomach will start having waves of peristalsis. So the food will be moving up and down between the fundus and the pyloric canal, and then you will have contraction of the circular layer and the longitudinal layer, and then the remaining of the chyme, as once it is completely mixed, it will start to be also forced out from the stomach as the process repeats. Right, any questions? Now for the small intestine. So our small intestine is subdivided into duodenum, jejunum, and ileum. So it has been extended so you can see it. Now the duodenum, it is retroperitoneal, and it has 4 regions. In the second region, which is this, that's where we have an opening, which is called the duodenopapilla. And in this opening, we have emptying of the contents of the liver, which is bile, and also the pancreas, the pancreatic juices. Now, for the jejunum, we have no acid production, same as for the duodenum, but we have absorption of these nutrients that we have digested in the duodenum. In the duodenum, we have this release of bile that helps to break down the lipids. The lipids initially are large, and then they become smaller with the action of another lipase that we have that is called pancreatic lipase. So we have 3 types of lipases. We have lingual, we have gastric lipase, and then we have pancreatic lipase. And then this lipase will start breaking down these lipids, but it is not enough. You have to have emulsification process, which is breaking down the large goblets of fatty acids into something that it can be assimilated. In that case, you use the bile from the liver, emptying here into the second portion of the duodenum. But the lipase that comes from the pancreas, it is released here because that's where we have the opening for the pancreatic duct, the main pancreatic duct. And then you will have then these lipids that can be absorbed into the lacteals, which are found in here in the enterocytes. So now the intestines, no matter what region it is, if it's jejunum, duodenum, or ileum, they have these plica circularis, or circular folds of mucosa, that just as for the rugae of the stomach, you will have increased surface area for action like digestion and absorption of the nutrients. Now, if you magnify one of these plica circularis, what you will be able to see is the epithelium, which is just like as the one from the stomach, simple columnar epithelium with goblet cells. And then inside this microvilli, villi, which is the actual name of this part of the epithelium, the villi, you will have the lacteals, which are the lymphatics that can absorb the fats that were previously digested by the lipase enzymes. And then, of course, we have these capillaries that provides blood supply to all of this tissue underneath. And then the bottom of this villi is called intestinal crypts. And then if you magnify one of these cells, an enterocyte, you will have microvilli in these enterocytes. And in the microvilli, you have some enzymes that are called brush border enzymes. These brush border enzymes will be made out of different kinds, like trypsin, chymotrypsin, and carboxypeptidases. Also, we will have lactase enzyme that can break down carbohydrates in the case of lactase, and in the case of trypsin, chymotrypsin can break down these polypeptides into individual amino acids so that you can absorb them. And now, in the small intestine, you have, just like as for the stomach, you have contraction, relaxation of the muscular wall that will allow this food, the chyme, to be located in a long area like this instead of a small portions, all confined. So you spread your food, your chyme, internally. The reason for this, with this contraction of the circular muscles and the longitudinal muscles, you keep it like this because you want to have more action of the enzymes over this. It's much easier, and it's good that it presents this food like this inside the intestines. So here we have a clump of food, and here we have a very thin strip of food. If you have enzymes, the enzymes will be located here within the wall of these intestines, but also some, of course, are going to be secreted. But imagine how long will it take for an enzyme to reach the center of this food versus this thin strip? Well, it takes longer, right? But that process is actually to make it like this, to compact the food, and then to make it open for the action of the enzymes. But at the same time, this one, don't think that it's going to be left like that. So this one is going to also be compressed and make into a thin film so that you can have better digestion. So this peristalsis is called propulsive, and while this one is going to be called segmentation. In segmentation, basically you have a relaxed longitudinal muscle, and then your circular layer clips the food, and then once you do that, you start doing this peristalsis with propulsive movement so you can thin out the food and then you can digest better. So now for molecules that affect the motility of your digestive organs. So we have hormones from the stomach, like gastrin. Gastrin is going to stimulate the secretion of acid by the parietal cells, and also is going to increase the motility of the stomach, because it's going to stimulate the vagus nerve. What is going to be the stimulus for gastrin? Digestive proteins. So a protein-rich food is going to stimulate the release of gastrin. Now, histamine, which is kind of a local hormone in the stomach, is going to be stimulated the secretion of histamine by a stimulation of the vagus nerve. And this histamine is going to act over the parietal cells so that the parietal cells produces acid. And then serotonin is going to be secreted when your stomach is distended, and that stimulates gastric motility, same as for gastrin. And then somatostatin is going to be a hormone that is going to have kind of antagonistic effect for the secretion of acid by the parietal cells. So once you have enough hydrochloric acids, there is no more need to secrete more hydrochloric acid. So in this case, you secrete somatostatin when you have a lower pH in your stomach, and that will prevent your parietal cells to produce more acid.
So is it like a buffer?
It's like a buffer, actually. And just think about it this way. Sometimes when we fast, we don't need to produce more acid, right? So in this case, somatostatin is sensing that you already have a lower pH in your stomach. So why would you have the parietal cells producing more hydrogen ions and more chloride to form hydrochloric acid if you already have an acidic stomach, an empty stomach? It's a waste of energy, right? So then in that case, you have somatostatin. Now, some of these peptides that come in the proteins or amino acid that comes in the proteins can neutralize the pH of the stomach once you ingest them. So in that case, the increased pH or pH that goes above the normal acidity of the stomach will stimulate the secretion of acids by the parietal cells, which in itself is going to stimulate the formation of pepsin out of pepsinogen so that you can digest the proteins. So that's the purpose. Now, we have other hormones. In this case, these will be intestinal hormones like CCK or cholecystokinin, that this one is secreted by duodenal cells, and this cholecystokinin helps us for secreting bile. So the gallbladder, which is the storage form, which stores the bile in the liver, will be there until you have CCK. So once CCK is released, then your gallbladder is going to contract and it's going to release this bile, and then you will have the emulsification of lipids by the bile, and then you will have the partially digested proteins also that stimulates the release of CCK, helping to relax this sphincter that not only helps for the bile to be released from the gallbladder, but also enzymes from the pancreas to start breaking down the lipids like pancreatic lipase, and also some of the proenzymes like trypsin, chymotrypsin. So CCK, it's an important hormone. So after I cover this, we will have a break. But then GIP, which is stimulated the secretion when you have chyme entering into the into the duodenum, this one is going to be antagonistic for the secretion of acids from the parietal cells, just like a somatostatin. That's why it's called gastric inhibitory peptide. And then for intestinal gastrin, this one is going to be released when you have chyme entering to the small intestine, and it's going to stimulate the secretion of acids from parietal cells. So anytime that you hear gastrin, it's going to stimulate the secretion of hydrochloric acid by the parietal cells, no matter if it's intestinal or if it's gastric. Why we have two? Well, just in case that someone has gastritis and these parietal cells are all eroded, you still have intestinal gastrin that hopefully for the remaining of the cells that are healthy, the parietal cells, they can release hydrochloric acid. And now we have another one that's called motilin, that it is actually released during fasting, and this motilin stimulates the migrating motor complex in the small intestine. So basically, it stimulates this and this, so that you can move the food from proximal regions into distal regions. And now secretin, which is released by duodenal cells under the presence of digestive proteins, is going to inhibit the motility of the stomach. So basically, the stomach will mix the food, will pass it into the duodenum. If you have partially digested proteins, that is going to lead to the release of secretin, and then secretin will prevent more secretion, more release of food into the duodenum, because you need to have time to process first one batch of chyme, and then once it's ready, then you start secreting the other ones, like this one, CCK, so that you can receive another batch. So everything is between secretin and cholecystokinin, so that you can have food little by little. And then not only secretin inhibits the motility of the stomach, but also stimulate the release of bicarbonate by the pancreas. Many of these enzymes from the pancreas, they work with a pH that it is neutral. And now, bicarbonate is not only for the functioning of the enzymes, but also the chyme is very acidic. So you need to neutralize it with bicarbonate. And this secretin increases bile production by the liver. So if you are releasing bile, then this one makes sure, this secretin, that you form more bile. And then we have VIP, or vasoactive intestinal peptide, that is going to inhibit the secretion of acid by the parietal cells, and is going to increase the intestinal blood flow, because it's not only digesting food, but also you need to absorb the food. So that's why you have to have more blood flow. And this, together with the presence of bicarbonate in our blood, it makes us to feel sleepy after we eat. Okay? Because the blood flow goes from areas of our body that keeps us alert, like the brain, into the stomach. And it, well, not only to the stomach, but into the intestine. So that and the presence of bicarbonate help us to feel sleepy after we eat. So let's have a 5-minute break, and then so now for the large intestine. So large intestine, it is a muscular organ that is more in charge of absorbing water, producing some vitamins with the presence of bacteria, and eliminating undigested food. So after the after the ileum, which is here, we have the first part of the large intestine, which is the cecum. And we have a valve, which is an sphincter, that is called the ileocecal valve. And this is the appendix. So now we're going to move to see this part in here. Okay, so we already saw duodenum, jejunum, ileum. As we move from from duodenum into ileum, the plica circularis decreases, and then absorption of nutrients decreases as well, but you have a lot of absorption of water. And in the ileum, again, is where we absorb vitamin B12, and all of these membranes are the mesentery. Now for the large intestine, then we have the cecum, which is the first part, and then we have the vermiform appendix, ascending colon, it's on the right side, goes from cecum up to hepatic flexure, and then this ascending turns from right to left, almost horizontally, so this will be the transverse colon. And then in the ending of this transverse colon, you have a downturn, which is going to be called the splenic flexure. And then you have descending colon, and then you have an S-shaped turn, which is called sigmoid, and then you have the rectum and the anus. So now, the large intestine is called large intestine because it has a greater width than the small intestine. And that greater width helped to be partially storage for undigested food to be temporarily stored in here before elimination. And then in the wall internally, in the mucosa of the large intestine, we have multiple types of bacteria. And this bacteria is normal bacteria that helps to break down undigested food to make it softer. And then depending on the amount of water that you ingest is whether your feces will be compact or will be semi-soft. But basically, the action of the bacteria on the food, it's supposed to make the food to be less hard, and then, of course, less harder to eliminate. Now, just like the alimentary canal, we have muscularis layer. So now, the muscularis layer, the circular layer, it is complete in the entire large intestines. However, the longitudinal layer, it is only a thin strip that we know as taenia coli. So we have complete circular layer in the muscular wall, but the longitudinal layer, instead of surrounding the entire lumen, is going to be only found in here. And the large intestine is characterized not only for being wider than the small intestine, but also by having these outpocketings that we call hastras. So it's very characteristic. And in the serosa, you have this fatty tissue that hangs mostly from this taenia coli that are called epiploic appendages. And now, the epithelium, which is still the same as the alimentary canal, which is simple columnar. In the case of this epithelium in the colon, it has abundant goblet cells. The reason for this is because, this is the part where we have undigested food, food that is going to be about to be eliminated. And then let's say that someone doesn't drink as much water. Well, the body itself, it can absorb water still in here to help us to be hydrated. But what is going to happen with the food that we have inside? So it's going to be much harder, it's going to dry. And what do you need to help to eliminate that? Well, you have to have mucus, a lot of mucus in the epithelium. So then you have abundant goblet cells to lubricate this, and then the food can go from cecum into ascending, into transverse, into descending, into sigmoid, and into rectum and the anal canal. And then, of course, we have a membrane that holds this intestine, which is the mesocolon. That's the name of the mesentery, the mesocolon. And then this organ has dual blood supply. It has blood supply by two branches. The superior mesenteric here on this part, and inferior mesenteric in this part. And then the external anal sphincter is made out of skeletal muscle. This is voluntary, while the internal is involuntary. It's made out of smooth muscle cells. And then details about the anal canal. So here is the rectum. Here we have valves in the rectum. And then here in the anal canal, we have these anal sinuses in between these anal columns. And then we have a transition of epithelium. So this epithelium, that it was simple columnar, now below these anal sinuses, we will have this same epithelium that we have in the skin, which is a stratified columnar stratified squamous epithelium with keratin. And then here we have the internal anal sphincter, and this will be the external anal sphincter and the levator ani muscles. Then, of course, we have as well in this epithelium, the last part of the simple columnar epithelium, we have all of these glands that secretes mucus. So for the defecation reflex, we have stretch receptors that sends the signal from the anal canal into the spinal cord at the sacral region. And then this afferent signal coming from these receptors, from the sacral nerves, make a synapse with these receptors of the parasympathetic system in the sacral area, and then you will have, the stimulus itself is going to be this tension, but then you will have a series of nerves that are going to make these muscles to contract, and that will hold the undigested food until it's ready to be released. If the stretch is so much of these receptors, and if it's ready to be eliminated, the food, this short reflex will be converted into a long reflex, in which you will have input, voluntary control from your cerebral cortex going into this spinal cord, making synapses in these motor nerves of the spinal cord, so that you can relax this external anal sphincter. And then that will let the food go. So you have a short reflex and a long reflex. The long reflex, of course, always involves voluntary control and relaxation of this external anal sphincter. Now for the accessory organs. So this is the pancreas. The pancreas has like a shape of a hammer, if you want to see it that way. This is the head, this will be the handle, right? But the pancreas head, it is in close contact with the duodenum. The duodenum has kind of let's see, yeah, it has a C shape that embraces the head of the pancreas. And then this is the head, this is the body, the largest part, and this is the tail. From head to tail, you have the running of these ducts. You have one that is called the main pancreatic duct, and then you have the accessory pancreatic duct that emerges off from the main pancreatic duct just in the head. And this duct receives secretions coming from the hexocrine portion of the pancreas, which will be the pancreatic acini. The pancreatic acini has these cells that produces bicarbonate, produces the enzymes, and releases this secretion into these ducts. That all these ducts will form this main pancreatic duct, and then these secretions of bicarbonate and enzymes will enter into the major duodenal papillae through this main pancreatic duct or into the minor duodenal papilla through this accessory pancreatic duct. Now, in this major duodenal papilla, not only the main pancreatic duct empties its secretions, but also the common bile duct. The common bile duct empties the bile from the liver. So this is the gallbladder. The gallbladder stores the bile that is produced by the liver, and then it empties it together with these pancreatic secretions. Now, the enzymes from the pancreas are inactive. They only get activated into here. So they are proenzymes. If it would be active in here, the pancreas itself will have out of digestion, which sometimes can happen. When this is obstructed, these enzymes can be activating here and the person will have pancreatitis. So then 99% of the tissue of the pancreas is exocrine, while only 1% is endocrine. The endocrine is made by pancreatic islets or Langerhans, and in here we have the production of insulin, glucagon, and somatostatin that controls the levels of glucose. And these secretions enters into the blood vessels, that's why it's endocrine. While these ones empty into the duodenum, which is part of the external part of our body, or the lumen. And then these enzymes that get empty here as proenzymes will become activated under the right pH, which is going to be basic. That's why you secrete also bicarbonate. And now, why we have an accessory duct? Well, oftentimes the gallbladder has stones, and one of these stones runs through this common bile duct, and it can occlude this pancreatic duct. If it occludes the pancreatic duct, of course, the enzymes and the secretions won't be released into here, but still part of it can be going into this accessory duct. It's not perfect, but it's better than nothing while this problem is found, and then you can have surgery. So here is a mode for secretion of this pancreatic juice. The juice is basically enzymes, bicarbonate, water. So you will have these duodenal cells that releases secretin. Secretin enters together with cholecystokinin into the bloodstream, and then this reaches the acini, the acinar cells from the pancreas, and then you have CCK binding into these receptors, and the secretin binding into the duct cells. and then you will release bicarbonate and enzymes. And then all the pancreatic juices will empty into this second portion of the duodenum so that you can have active enzymes. Questions about the pancreas? Okay, now for the liver. So the liver is the largest gland that we have in our body. It's part of the digestive system. It's very important. And it has an anterior view where you can see these lobes, the major lobes, which is the right and the left. They are separated by this ligament that is called the falciform ligament. And then internally, the falciform ligament has a ligament that is called round. Underneath the right lobe, which is the largest lobe, you have the gallbladder, that is a muscular organ that is a temporary storage for bile. Bile is basically a byproduct of degradation of red blood cells, and it helps to emulsify fats so that we can absorb them once we digest them with lipase. So if you look underneath the liver, this is the inferior view, you can still see the right lobe and the left lobe. And here is the round ligament. Now we have minor lobes that are called the caudate, that is by the inferior vena cava. And then we have the quadrate that is located between the round ligament and the gallbladder. Quadrate because it looks like a square. And now, this part just anterior to the quadrate lobe, it is called the portal hepatis. This is basically the hilum of the liver. That's where blood vessels come in and out, and then, of course, we have these ducts for the bile. So we have here the hepatic portal vein that brings nutrient-rich blood into the liver so that the nutrients can be processed. And then we have the hepatic artery proper, which is a branch of the celiac trunk. And then here we have the common hepatic duct that results from the merging or the anastomosis of the left hepatic duct and the right hepatic duct. And then this common hepatic duct merges with the cystic duct that it is draining the bile from the gallbladder into the common bile duct. So the common bile duct is then the anastomosis of the common hepatic duct and the cystic duct. And then the gallbladder has a fundus, which is this, a body, which is this, and the neck. And this is a muscular organ that has smooth muscle, and then this organ is constantly doing this, is contracting to mix the bile. And then sometimes this one becomes a little bit lazy, so it doesn't contract as much. And the salts of the bile precipitate, and that's how you form the stones, gallstones. If you take a section of the liver and you look at the histology, the units of the liver are lobules. Lobules have a hexagonal shape. And at every vertex of the hexagons, we have the portal triad. A portal triad is made by a hepatic arteriole, a portal venule, and a bile duct. And then in the middle of these lobules, which are these, we have the central vein. So this is actually a view of a liver tissue with light microscopy. So this is the central vein, and this is where we're supposed to have these portal triads, which are these. And then emerging concentrically from this vein, we have, or surrounding this central vein concentrically, we have these rows of hepatocytes. So if you magnify this, you will be able to see these hepatocytes surrounding these hepatic sinusoids. These hepatic sinusoids basically bring blood from the portal venule into this vein. So this is how the venous blood drains from this portal venule into this central vein. And then the arterial blood is going to run in opposite ends, like from the central vein into these hepatic arterioles. Now, these sinusoids receives proteins that are made by the liver. The liver basically is the major organ in our body that makes the proteins. So, and then we have then these hepatocytes, and when these hepatocytes receive the heme from the destruction of the red blood cells, that heme partially is going to be converted into bile. And that bile enters into this bile canaliculus, and then this bile will go in the opposite direction of the blood flow from the venules into the central vein, so it goes here into these bile ducts. And all of these bile ducts form a single hepatic right duct and a left hepatic duct, and both of them merge, forming the common hepatic duct. And then the common hepatic duct joins the cystic duct, and then you have the common bile duct. So here we have then the left hepatic duct and the right hepatic duct joining, forming the common hepatic duct. They carry the bile from the liver, and when the bile is not going to be used, that bile will enter into the cystic duct, will be stored into the gallbladder. The gallbladder will keep it mixed by contracting and relaxing. And then once you eat proteins or lipids that enters into the duodenum, you release CCK. CCK makes this to contract, and then that contraction opens a wider opening in the cystic duct so that the bile goes and empties into the second portion of the duodenum. And then the cystic duct, when it merges with the common hepatic duct, forms the common bile duct. And here you can see an imaging of the gallbladder with gallstones. Some gallstones are radio opaque, so you can see them, but some of them they cannot. One way to suspect this is by the person having a pain in the right upper quadrant, and then you take the imaging. Of course, you have to ask if the person has already removal of the gallbladder, right? I'm kidding. So then, when you have a bunch of gallstones, there is no need to even try to destroy them, like if you do with the technique that you do for the kidney stones. So this one definitely has to go out. And then there are different type of gallstones. Again, some of them, like the ones that has calcium salts, calcium, it is radio opaque material. They can be shown, but others, they are not shown. So not just because you don't see that, that doesn't mean that the person doesn't have gallstones. And then the removal of these will be called cholecystectomy. Can be through laparoscopy or open. And then this is how the secretion of bile happens then. So you have a full gallbladder with bile, then the nutrients that makes the CCK to be released, like proteins and lipids, enters into the duodenum. You release CCK into the bloodstream, and then you will have receptor for CCK here in the gallbladder, and then you will release the bile. And after that, you need to replenish to make more bile, so that secretin will be released, and then you create more bile, and then you start the cycle over again. Now, something that happens when someone has removal of this gallbladder is that the person is not going to have this bile to be released into the duodenum, so to emulsify fats. So one of the dietary restrictions then after having cholecystectomy, it is to avoid these fatty foods because the fat will appear in the feces. This is called steatorrhea. Okay, so summary for the function of the accessory organs. Salivary glands produce saliva to start digesting starch, to start digesting lipids, and also to protect our body against bacterial infections with IgA and lysozyme. The pancreas basically help us to digest lipids, carbohydrates, proteins, and as well, it helps to control levels of glucose with glucagon and insulin. And then the liver with the production of bile that is stored in the gallbladder. It helps to emulsify lipids so that they can be broken down by the pancreatic lipase and can be absorbed. Because if you don't emulsify them and if you don't use the lipase, then they won't be absorbed. So that's all for this chapter. Do you have any questions? Okay, so